Hi, I'm Sonu Jain at the University of Cincinnati, and I would like to welcome you all to our combined hand-in-hand webinar series of the American Association for Hand Surgery with the American Society for Peripheral Nerve. Today, we're going to have a discussion on electrical stimulation and nerve wrapping, the great debate. I really would like to thank Checkpoint for their generous sponsorship of this program, and I'd like to introduce our moderator, the esteemed Dr. Nash Nam, who is former president of the Hand Association. Nash.
Good evening. Thank you so much. Thank you so much, all of you, for joining us. We all know that in spite of the fact that the peripheral nerves have the ability to heal, we still have difficulty to get good functional results and outcome from nerve repair. So we try to find methods to enhance the functional results of nerve repair. And tonight, we'll have the honor of listening to 4 fantastic speakers debating the two specific issues. The first one is electrical stimulation, and the second one is nerve wrapping. We have a fantastic faculty, Dr. Greg Borschel, Dr. David Brogan, Dr. Jonathan Isaacs, and Dr. Mark Rickan. We'll start first with Dr. Borschel. Dr. Borschel, he's a professor of plastic surgery and the chief of hand surgery, chief of plastic surgery at Royal Hospital in Indianapolis, in Indiana. And he will talk to us about the electrical stimulation. Greg?
Okay, thanks so much, Nash. I appreciate the very kind introduction. And I'm going to go ahead and start sharing my slides. Okay, hopefully everybody can see this. And I've been asked to talk about 20 hertz intraoperative electrical nerve stimulation, how it works, and how to use it. Feel free to reach out. I put my email at the bottom here. And please feel free to put stuff in the chat, and we'll get to it as much as possible. So what's going on here? We know that with nerve regeneration, the regenerative capacity of nerve deteriorates with time. And Tessa Gordon, pictured here in the top right, is a neuroscientist who's really spent a career demonstrating this, as well as pioneering electrical stimulation. So as you can see in the graphs here, if you have a nerve injury and you do a repair, only after 60 days, so over here, 60 days, 2 months, you lose half the capacity of that nerve to regenerate. Either looking at the neuron cell bodies or the Schwann cells, the same thing is true. So even after just 2 months, we lose a lot of ability to regenerate. And so one possibility is to harness the ability of 20 hertz electrical nerve stimulation to enhance regeneration after injury and repair. This is a paper from 25 years ago that looks at the effect of applying 20 hertz electrical stimulation, and this series applied at 1 hour. This is a femoral nerve model in rat, and you can see that there's quite a bit of a difference looking out 3 weeks or even 4 weeks or 5 or beyond compared with sham stimulation. So that's a very early paper. I'm going to walk through some of the more recent data, preclinical, and then move on to clinical, and then talk about some of the practical applications. So how does this work? What are the effects of electrical stimulation on the neuron cell body? Well, there's a whole bunch of different things. It turns out there's upregulation of brain-derived neurotrophic factor, GDNF as well, their receptors, and intraneuronal cyclic AMP. Then over here, this is from a review that we published. Lead author was Kevin Zhou. You can see there's a large cascade of molecules that lead to ultimately transcription and cytoskeletal element elaboration that drives nerve regeneration. So here's one study that we did in our lab. The nerve autograft is a very challenging model, but it's something that a lot of us do every day. So the question was, can we use electrical nerve stimulation in autografts and get an effect? And of course, as we know, with nerve autografts, there's 2 coaptation sites, long distances, axonal regeneration is very slow. So what can we do to improve the impact on functional recovery, which, as we all know, is rarely complete? So in this study, we wanted to investigate if a single session of electrical stimulation enhances axon regeneration, in this case through a short 10 millimeter nerve autograft. And then in another study, we wanted to look at whether a second delayed session of electrical stimulation further enhanced axon regeneration compared to the single session through an even longer 20 millimeter nerve autograft, which is quite a challenge in a rat model. So here we are. This is common peroneal nerve model in the rat, excised, replaced. This is an autograft, 10 millimeters in length. And then in the stimulation group, we applied electrical stimulation to the proximal stump. It's got to be applied to the proximal stump, either in rat or a human situation. And then we looked at some outcome measures. We looked at retrograde labeling, looking at how many neurons regenerate their axons. And we looked at histomorphometry, trying to answer the question of how many axons regenerate into the muscle. And then we looked at functional outcome measures as well. So to do the retrograde labeling, as shown here, after regeneration, the end of the nerve is tucked into a dye well, and then these dye molecules are taken up retrogradely into both the motor neurons in the ventral horn and also the dorsal root ganglion cells. This is what they look like in the spinal cord, and then they can be counted. So here's the data that we found. Bottom line, electrical stimulation increases motor and sensory neurons that regenerate their axons. This is at a time point of 6 weeks, and you can see that there's a statistically significant increase, both with motor neurons, as shown on the left graph, and also sensory neurons on the right. And this is a time point of 6 weeks. Likewise, electrical stimulation increased the number of myelinated axons that regenerated. Again, statistically significant in this model. So we can conclude that a single session of electrical stimulation enhanced axonal regeneration through this shorter 10 millimeter nerve autograft. And again, we wanted to ask the question, what if we apply this more stringent model and ask the question as well, what happens if you stimulate twice? If one is good, is two better? So in this model, we have sham stimulation used twice, or one single bout of E-stim and a sham, or double stimulation separated weeks apart. So here we are, same common peroneal nerve model, autograft model. We do the surgery, apply electrical stimulation, or apply sham stimulation, 4 weeks of recovery, and then in surgery 2, we re-expose the graft, and then performed a second bout of E-stim or sham. Same outcome measures used, retrograde labeling to count neurons, histomorphometry to count axons, and looking at muscle mass too. So we found that E-stim increased motor neurons that regenerated their axons, but 2 bouts of E-stim was no better than 1. And this was true for both motor neurons and then also the sensory neurons, as I'll show here. This is sensory. Again, we saw a nice increase in the number of neurons that regenerated their axons, but sensory, like motor, did not improve with a second bout of E-stim. And this is captured in a paper in experimental neurology. This is looking at the number of myelinated axons that regenerated, and likewise, there was no difference with 2 bouts of E-stim versus 1. And this was true for motor and sensory as well. Here's another paper from a different laboratory. This is out of WashU, looking at the question in a different way. So here, instead of 30 minutes, they were looking at 10 minutes of electrical stimulation versus either 0 or sham stim or 60 minutes. And here you can see these are all individual axons regenerating. This is a repair site. And here with 10 minutes of E-stim, we're seeing some axons come in. Likewise, 60 minutes, axons coming in. So they determined that 10 minutes, even after only 10 minutes of E-stim, compared to what we did in our study with 30 minutes, was still exerting an effect. So now I wanted to look at a few clinical trials. All of these trials are level 1 evidence. That is, they're randomized sham-controlled trials. This is a group out of Edmonton. This is the first clinical trial. This is looking at carpal tunnel, either stimulating or sham stimulating post-repair. And the way they did this was actually in recovery. So they placed the leads in the OR, went to recovery, did the stimulation while awake in recovery. And they determined that there was a difference from an electrophysiological outcome measure with the number of motor units. Another study that's been published by the same group, Edmonton, is looking at cubital tunnel release. And they found that after 3 years, there were significant increases in the E-stim group versus the control group when looking at functional outcome measures including grip strength and key pinch strength. So this is the first paper to show a functional outcome improvement with eStim. Here's another paper looking at digital nerve repairs, same stimulation protocol, and then the outcome measures here. We're looking at moving two-point discrimination, static two-point discrimination, Semmes-Weinstein monofilament testing, and looking at cold and warm discrimination tests. And likewise, they found a difference where the eStim exerted a benefit over the sham controls. Here's another study. This is looking at spinal accessory nerve function following eStim or sham stim with modified radical neck dissections. And the outcome metric here was something called the constant Murley score, which is a functional outcome measure of shoulder activity. And here again, they determined that there was a difference when using eStim. How do we do it in our center currently? We use, it's actually quite simple. We use a cortical stimulation box. This is a device produced by a company called Nicolette. It's something that any center that does craniotomies or spine surgery will have. There's an extender cable shown in the bottom right, and then into the extender cable, we insert these electrodes as shown in the top left, which are the same electrodes that neuromonitoring physiologists will use during spine surgery or craniotomies. And then we put them on the nerve of interest. Again, it has to be on the proximal stump. Very important. And the final common pathway is that it has to elicit an action potential. So you can think of it as kind of like jump starting the nerve. Now, the settings are very important. 20 hertz, and any electrophys person can do this. They can program this for you. 20 hertz, 1 to 2 milliamps, biphasic waveform, so it's going up and down. 30 minutes is what we use in our center, but that can vary. And then the pulse duration is 100 microseconds. Here's a brief video to show what we do in the OR. Here we're doing a spinal accessory nerve to suprascapular nerve transfer. We place these stimulator leads. Again, these are just the same stimulator leads that any neuromonitoring group would have. They're very inexpensive. They only cost a few dollars, disposable. So we apply this stimulation. Here we're applying it at 1 milliamp. And then in this case, since we're going to do another transfer, we simply staple it off, let the stimulation proceed, and then move on to another site. In this case, we're doing a triceps to axillary nerve transfer. So we've stapled off the 11 to SSN. Go ahead, do your regular transfer as you ordinarily would. Place the leads on the donor nerve. And again, it's got to be on the proximal stump. Here, this is an infant. So even with very small nerves, you can still apply these electrodes and leave them in place for 30 minutes. Although again, as I indicated, there is some emerging data that suggests that you don't need to stimulate for that long. It might be as low as 10 minutes. Here's another way to apply it. You can use tiny wire electrodes and place them directly, again, on the proximal stump. This is how the Edmonton group had reported it. And then another way that's emerging, this is a checkpoint stimulator, and then they've recently come out with a connector electrode, as shown in the bottom right and the top right, and that can be placed on the nerve. I haven't tried this myself, but I'm eager to try it. And I'd love to hear what people have to say about using this in their center. So to summarize, brief electrical stimulation enhances axon regeneration in nerve gap reconstruction. It can also be used in nerve transfers and also nerve decompressions, as well as autografts. Here's a few references. One of these is a review. One encapsulates the preclinical studies, some of which we did. And then one is a practical one, how it works, how to apply it, that was just published this year. So thanks. A lot of the preclinical work here was done by Kevin Zoe from my lab. Again, feel free to reach out and look forward to the comments. Thank you.
Thank you, Greg, very much. It's an excellent presentation. It seems like it's very convincing. Not all of us are convinced. So we'll have the different point of view expressed by our colleague, Dr. Jonathan Isaacs. He's the professor and chief of hand surgery and the distinguished research professor in the Department of Orthopedic Surgery at Virginia Commonwealth University in Richmond, Virginia. Jonathan?
All right, well, thank you, Nash. And Greg, thank you for that nice presentation. I'm going to go ahead and start sharing my screen. As I get going here, I want to just make a quick point that that this is a debate. I was assigned the opposing position, which I'm happy to present arguments, and hopefully I raise some points that are worth thought and further discussion, but in no way do I diminish the incredible work and effort that Greg and many others have put into this. With that said, my title is Low Frequency Electrical Stimulation, Too Good to Be True. I have disclosures, nothing that is relevant to this particular topic. Well, I think Greg and I would both agree, and probably most people in the audience would agree, that nerve repair outcomes are not satisfactory in general, and there is definitely a need to improve those outcomes. This effort, of course, is challenged by the fact that nerve regeneration faces a lot of different problems. Some nerve cells just die and don't even try to regenerate. We know there's atrophy of denervated muscle, denervated nerve. We know, as Greg mentioned, time-dependent loss of axon regeneration. There's issues with cortical plasticity and even issues with axonal loss, something that we're going to talk about hopefully in the next half hour. Well, out of this whole list, the one area that really would be affected by a slow rate of axon regeneration is the atrophy issues. Both of those, muscle and nerve, are definitely time-dependent issues. So if you said, well, wouldn't it be good to get faster axon regeneration? We would all knee-jerk say yes, it would be good. It would certainly address one primary obstacle, but I think there's some questions that we need to ask. Is it really possible? Are there downsides to doing this? Will it really improve clinical outcomes? And is it truly logistically feasible? Well, as we get going on this topic, I want to point out that nerve regeneration, and some of Greg's slides really show this as well, is an incredibly complex process. The nerve undergoes a complete metamorphosis from a cell specializing in signal transmission, which in itself is an amazing physiologic feat. But now the cell is single focused on regeneration. There's a huge genetic shift, upregulation of cytoskeletal proteins. Phytopodia reach out and explore the environment looking for suitable pathways. And when you think about all that is going on, it's from a physiologic standpoint, the nerve is actually regenerating really fast. And just for comparison, fingernails regenerate at 3 millimeters a month and hair at about ½ an inch a month. So remarkably faster than those other tissues. One of the concepts that I thought Greg would talk about, but he didn't, is and this is the same Zal that he referenced several times, and if I understood, works in Greg's lab or has worked with him. When a nerve is repaired and you have a coaptation, the axons don't all cross the coaptation at the same time. Some cross sooner than others, and in fact, in this study, they showed that it takes 8 to 10 weeks for all the axons to cross this coaptation. We call this a stagger start. What eStim does, or at least one of the primary mechanisms of how eStim works, is that it eliminates the stagger start, but it does not accelerate nerve regeneration. So in this study, instead of 8 to 10 weeks, now the axons all cross the coaptation in 3 weeks. But they don't continue to regenerate faster and faster. So the overall decrease in time to reinnervation is really measured in a matter of weeks, and that would be regardless of regeneration length. Now, some of this information comes from studies like this. 2 weeks post-repair, you eStim at the time of repair, 3 times the number of motor neurons versus controls downstream. But at 4 weeks post-repair, that difference is much less. Interestingly, the same type of studies where you stimulate a rat sciatic nerve and look for axons downstream actually has shown that the eStim can misdirect the axons. In this study, more axons were found in the perineal nerve after E-stim of the sciatic nerve. So misdirection definitely increased. And in this study, if you just stimulate the perineal nerve, you actually get more axons almost forced into the tibial nerve compared to control groups. And what's going on in a normal nerve is worth thinking about. In untreated nerves, only 25% of the axons cross the repair in the first week. Well, that makes sense with some of the data I just showed you. But look at what's going on during that first week. The axons actually travel laterally across the face of the distal nerve stump, or many axons arborize to go down multiple endoneural tubes. And from a mathematical perspective, if you think about what's going on, that wandering single axon can sample almost 150 different endoneural tubes during that first week, and those arborizing axons actually could sample about 70 tubes in that first week. Now, many axons do remain in endoneural tubes. Some do not. Some are redirected, some pruned. This may be related to both positive and negative pathfinding cues. But it certainly makes you think that if you force axons to speed across a coaptation, maybe you're losing an opportunity. Maybe those axons are no longer looking for the proper pathway, and you have increased axon misdirection. And I might add that we're talking about rat sciatic nerves or mouse sciatic nerves. When you think about a human polyfascicular nerve, this may be a much bigger issue. And really, while we certainly care about the rats and mice and we want them to do well after their nerve repairs, what we really want is we want to see major peripheral nerves in humans do well. Let's take a brief look at some of those papers that Greg referenced. And I identify the exact same four published studies. Yes, during the spinal accessory nerve stimulation after radical neck dissection, they did show that at 1 year out, the patients who had E-stim had better shoulder function. But what Greg didn't tell you is that there was no difference in final electrophysiology studies, no difference in final CMAPs. And the actual amount of nerve damage was never documented. We don't know whether the nerves improved or they were better from the beginning. In the digital nerve study, 18 patients per group, so actually quite a few patients in that. Yes, the study, as Greg pointed out, showed improved 2-point at 6 months out, but 87% of those patients achieved normal, and that is really good. It's almost too good when you think about the mechanism by which the axon regeneration is improved. What I just showed you from rat models, it shouldn't be this much better. 24% normal recovery in a systematic review. So that's a big difference, almost too big of a difference for the recovery there. The carpal tunnel release study, E-stim in 11 patients, 10 controls. E-stim, all patients, motor units the same as normal thenar muscles. So almost complete muscle recovery in the E-stim group at 1 year out, which sounds great, which is amazing, except that there was no differences in the patterns of sensory recovery. Hand function was the same in both groups. There was no differences, subjective complaints, and no statistically significant improvement in latency in the control group, which is worse than they should have done. So the treated patients did better than you would have predicted. The control patients did worse than you would have predicted. And finally, the cubital tunnel study that Greg referenced followed each patient annually for 3 years out. And yes, as Greg pointed out, better electrophysiology from muscle testing and 3 times main gain in pinch strength, which sounds great, except there was no statistical difference in grip or pinch between control group and E-stim group, and there was no actual data on subjective or functional outcomes. To me, that at least introduces a reason to question some of those results. And then finally, the logistical challenges. Local anesthetic blocks the effect. I don't think Greg said that. He said that you had to stimulate the proximal stump, which is correct. But if you have regional anesthesia, it prevents the positive effects of the E-stim. So cases historically done under local or regional must be done under general. And in certain circumstances, I think we can all see that that would be a big deal. Currently, there's no commercially available devices. The checkpoint electrode that Greg showed, while certainly is appealing, I don't believe is commercially available yet. And well, at least conventionally, this technique adds up to an hour per case. Greg pointed out that it can be done in 10 minutes, and certainly there's one study that's extremely supportive of this position. This is out of Washington University in St. Louis. It's a mouse study, and it's remarkably good with regard to showing how good eSTEM works. Greg already pointed out the positive retrograde labeling response at 7 days, better in both the 10 and 60-minute eSTEM groups. Histology at 14 days out is better in the stimulated group. At farther time points, muscle weight recovery, walking tests, everything looks better. It's a remarkably good study. But if you go up just one phylogenetic species higher, from a mouse to a rat, the changes are quite pronounced. A similar setup to the study, 10 minutes, 60 minutes in a sciatic nerve repair model versus controls, a couple different time points. Greg showed this slide. And it's really impressive that the 10-minute group had so many axons regenerate so fast, but it's actually better than the 60-minute group. So it's better than all the data that's been collected. This one study says, nope, 10 minutes is better. But wait a second, when you look at the histology, there's actually more axons in the control group at 2 weeks out. So really kind of conflicting data. So I'm not convinced. The GFP, the bright green pictures showing axon regeneration, and the conventional histology results are conflicting. And at least in one outcome measure, the 10 minutes was better than the 60 minutes. So should we be testing 5 minutes? Should we be testing 2 minutes? To me, this just doesn't make any sense. So in conclusion, I definitely accept that eSTEM eliminates stagger. It shortens regeneration time by at least several weeks, but increases axon misdirection, marginally improves clinical outcomes based on the studies that are out there. It is logistically challenging. And so, yes, to my title question, maybe it is too good to be true. And with that, I thank you for your attention.
Thank you so much, Jonathan. Excellent presentation, really appreciated. We're supposed to have a debate between the two previous speakers, but we are a little bit behind, so we are going to proceed with the next two presentations, and then we'll delay the debates for the two subjects to the end of the presentations. So the second subject that we're going to discuss is the nerve wrap. And the first speaker is my dear friend, Dr. Mark Recant, who is Associate Professor at the Department of Orthopedic Surgery at Thomas Jefferson University and at the Philadelphia Hand to Shoulder Surgery. Mark?
Thank you very much. I'm going to share my video, and I will work on sharing my screen and get us going. It's tough to follow those two brilliant talks, but a little bit more on the concept, again, as was described, a fun debate with really good friends, to wrap or not to wrap. And yes, it's good to wrap nerves. And most of this discussion will focus on non-transected nerve injuries, which can be a mouthful, so we can use NT and I. Just understanding the nerve wrap is a form of nerve protection using various sheets of material that will intubulate the nerve. Similar to G-stakes, there's lots that can be done. There are two different classes, similar to with or without. You have non-degradable, which have really fallen out of favor. For the degradable, whether it's bovine collagen or porcine mucosa or other options that you can see listed here. And you can have your cheesesteak any way you want when you come to visit me in Philadelphia. So why are they so good? They minimize ingrowth of external scar tissue. They can provide directional growth cues to the nerve, which we just heard about from Dr. Isaacs, and enhance functional recovery. So really, this is the classic. We've all seen these patients with a 62-year-old has more numbness than he did preoperatively. A a sense of thumb weakness with a history of a carpal tunnel surgery 4 months ago. And kind of what are we supposed to do with this? Is it an irreparable nerve injury? Is it incomplete decompression, a wrong diagnosis? And then what do? We could do nothing and reassure the patient that life will be good, move forward with just a neurolysis with nerve wrap, or the whole kitchen sink. And I think really the nerve wrap is going to help us minimize recurrent scar adhesions in patients that tend to form a lot of scar, improve nerve gliding, and it's easy to apply. And in this case, it would be used in conjunction with a patient at a prior surgery, in essence, to explain to them that, yes, we're not doing the exact same thing we used to do. So you'll hear about it a little bit later. We can also do this around a repaired nerve. Why the wrap? I quote my mentor and senior partner who wrote about this more than 10 years ago. And even the master has limited ability to control scar formation after revision surgery. And there are other papers, as you can see listed here, that have had similar frustrations with scar. Again, Ed Ackerman, who we all know, a wise professor, came out with a paper that showed 60% improvement. Well, that's wonderful unless you're in the 40% and didn't do so well. So there again, why wrap? Maybe we increase our 60% to something higher. Again, wrap benefits have been shown in various articles. There have been more than 50 papers over 50 years demonstrating improved nerve gliding, protection from perineural scar, and improving the microenvironment, which is sort of a work in progress in trying to better grade our nerve beds in these non-transected nerve injury cases. Here is something from the Pittsburgh group looking at neurolysis and porcine extracellular matrix nerve wrap in 2015, noting, again, this was effective and safe treatment with no further worsening. Now, of course, every patient didn't get well, but they found that no one did worse. So again, why not use the vein wrap? This is quite nasty. It's causing lots of scar tissue. And certainly patients don't want that second incision, even as elegant as it might be with our plastic surgery colleagues. So my thought is, if you're doing a revision carpal tunnel for this patient, why not give them the whole kitchen sink? And the triple therapy approach has been looked at using good surgical neurolysis, using a conduit of various methodologies, and again, throwing a hypothenar fat flap, which we all know fat is slippery and prevents further scar. And the authors of this paper in 2020, 25 or 30 patients had complete resolution of symptoms. And of course, there was added expense to the product, but the study felt that their response justified the costs. So this is kind of what that case looks like. Do a nice release, of course, add a little bit of a wrap, and add some flap around that, and you get the whole shebang. Tyson Cobb and Peter Amadio also looked at revision carpal tunnel, and again found only 1/4 of their patients would be completely satisfied in their case that did not involve a wrap or other situations. Again, we see this same story at the elbow with recurrent paresthesias in the ulnar nerve distribution. And again, this is what these beds look like. And I think if you just neurolysis again and leave it in a bad bed, you're going to have recurrent scar formation and an unhappy patient. So once the nerve is well mobilized, we can use a nerve wrap. In this case, it was an amniotic wrap. And again, a few slides on why amniotic can help. It does have anti-inflammatory modulators. It helps isolate the nerve from those inflammatory cells responding to the surgery. It also helps modify the surrounding soft tissues. Here you can see the list of growth factors that we find in the amniotic tissue, whether it's epidermal growth factor, fibroblast growth factor, and the others that you can see listed here. Again, what about nerve lacerations? I think conduits and nerve wraps are very helpful, and I'll just touch on this in 3 or 4 slides. You can see Dusick and others have wrote how conduits help realign those nerve fascicles and prevent axonal escape. John Isaac's paper showed good and excellent results with those types of repairs. Other benefits help keep those neurotraffic factors in the zone of the repair or neurophy. Again, help block scar tissue and prevent axonal escape, as I've mentioned. Maybe there's a better alignment method, and you can see here there's a wrap that be used in addition to prevent axonal escape, but also to better align the nerve ends with these micro hooks that you can see here on the top right. And it's an easy intubulation, and it's quick, reproducible with even the most basic resonant, and takes about 60 seconds to get an excellent nerve repair without tension. And it's similarly using this processed porcine submucosa that we have seen regularly in our nerve wraps for years, and we know those properties quite well. You can see there's a smooth surface that minimizes tissue adhesions and a scaffold for cell migration. And this has been looked at with tissue engineering in 2023, noting less scarring with regards to the nerve tape type of nerve repair. So in summary, nerve entrapments and adhesions remain problematic. More research, of course, is needed, although nerve wraps appear to be promising as a scar barrier and reduction of adhesions, minimizing further recurrence. Thank you very much.
Thank you very much, Mark. I really appreciate it. Thank you.
And thank you to our moderator and our webinar main man, Sonu Jain, who is instrumental in setting these all up.
I think Nash maybe frozen there, so I'll go ahead and introduce our next speaker here. Nash, are you on? If not, I can introduce David Brogan from Washington University Department of Orthopedic Surgery. He'll be talking about. Oh yeah, go ahead, Nash. Thanks.
I think I introduced him. Just, maybe it did. Oh, sorry, the internet connection went out. Sorry. So the next presenter is Dr. David Brogan. He's Associate Professor of Orthopedic Surgery at Washington University in St. Louis, Missouri. David?
Great. Thank you very much for the opportunity to join this panel. It's always fun to have these debates, and I've enjoyed the talks so far. I was given the contrarian, the anti-wrap topic, so I've taken the liberty to prepare somewhat of a cheeky talk titled Wrapping is for Presence, Not Nerves. This is ChatGPT's version of wrapping a nerve. These are my disclosures. Of note, I am on the medical advisory board and have equity in OrthoCell, which makes a nerve wrap. That's not yet available in the United States. Okay, so reasons that people commonly give for wrapping, at least anecdotally to me, to help the nerve glide better. People talk about how it glides so much better, to improve the vascularity that will magically make a sick nerve healthy and youthful again, to prevent fascicular escape from the coaptation, which, maybe perhaps it does, and then to protect it from the mean stainless steel plate that those nasty orthopedic surgeons will put on across that perfectly helpless nerve. So I'll talk about the types of nerve wraps. We'll talk about some of the studies. I will tell you what my guess at what Dr. Recant was going to say it was, and then I'll tell you why I respectfully will disagree. So as was previously covered by Dr. Recant, there are several different types of nerve wraps. There's kind of a laundry list and far more extensive than this. But bovine collagen, porcine extracellular matrix, and amniotic membrane are probably the ones that are the most commonly used or referred to today. But when I see these, inherently, I'm always kind of thinking, what would you actually say that you do with that wrap? How does that actually help you? And I think that's the mystery of these. So I think that some of the rationale for this comes from animal studies, and we've seen lots of animal studies so far, and I'll show you a few more. There are a number of ones that have looked at nerve wraps with different types. So this was a study that looked at a sciatic nerve crush injury, and they wrapped it with the PGA collagen. They wrapped it for 3 weeks, and they did a sacrifice surgery after that. There were 8 rats got just the crush, and then 8 rats got the crush and then the wrap. And they looked at sensory thresholds, motor evoked potentials, and histology as well. They claim that the short-term results were much better. But when you actually really look at the outcomes, only some of the outcomes showed some improvement. There was actually no difference in the motor amplitudes between the groups. Their latency results were mixed. Some of the latency measurements were better in the RAP group, and some of them had no statistically significant difference. They did, however, find that the axonal density was higher in the nerve RAP group, but they didn't discuss the size of the nerves that were generated, which are the diameter, which is important to understand, nor did they actually give you the total number, just the density. So limited studies there. There was another study that looked in rats that looked at type 1 collagen wrapping. And what they found is that actually didn't improve repair. So this is where they cut the nerve, they repaired the nerve, and they put a wrap on it on one of the groups. In another group, they did a sham. And then they did a number of other different types of repairs with either an interrupted epidural repair, a running epidural repair, fascicular grouped repair, or repair under high tension. And then they looked at these functional outcomes. So you put a rat on a rotor rod and see how long it can hold on, or you look to see when it walks through a ladder, how much it faults or the foot kind of drops through. And both of those are accepted ways of understanding how the rat functionally recovers with regards to the sciatic nerve. And ultimately, the collagen wrap didn't have a significant benefit to any of those compared to the other different types of repairs. Tension repairs tended to do worse, but the collagen wrap was not the panacea that one would hope it would be. So what about gliding? This was a study that looked in a rabbit model. Rabbits are good at scarring, and so they made 10 right limbs in the rabbits scarred, and they had surgery to induce scarring to simulate a kind of a cubital tunnel or carpal tunnel nerve compression. And then at 6 weeks, they either just sacked them and looked at the results, or they did a neurolysis and then also put a nerve wrap, the collagen nerve wrap around them, and then harvest them 16 weeks later to see if the nerve wrap ultimately improved the results. What they found was that the axonal density was really no different with the wrap or without the wrap in the scarred nerves or the control nerves, so there was no change. Then they looked at pull-out force, where they basically looked to see how much strength did it take to pull the nerve from the bed of the scarred bed. And so the controls were an unoperated kind of sham limb. And so more force means more adhesions. It's tight and stuck. The nerve is stuck to the bed. And in a control, it didn't take a whole lot of force, about half a Newton or so. In a scarred nerve, it took more force, 2 Newtons. And then what do we have here? When you put a collagen nerve wrap around it that's designed to help the nerve glide, it actually was stuck more. It took about twice as much strength as in just the regular scarred bed itself. So increased the amount of force required to remove it from the adhesions. Sami Tafaha and his group at Hopkins also looked at this and found that the extracellular nerve wraps actually did not improve repairs after a median nerve transection and repair. They studied at both 5 and 15 weeks. They found there was no difference in axons or myelination at any time point. Grip strength was actually higher in the unwrapped group at 6 weeks. At 15 weeks, this didn't really show any significant difference. The one kind of redeeming factor for wraps, I guess, was that they thought that there was less intraneural collagen in the wrap group at 5 weeks, but not at 15 weeks. All right.
You lost your slides.
Oh.
Rightly so, given the talk you were giving, but
hang on, let's see what we can do here.
I think you have to share your screen again.
Let's try that. Okay, where did you lose me? Rabbit or Sami?
Sami.
Okay. How about that? Okay. So the wrap group, unwrap group, no difference really. Grip strength is higher in the unwrap group at 6 weeks, not at 15 weeks. A little bit of collagen difference at 5 weeks, but again, 15 weeks. So putting a porcine wrap around at the ECM didn't really help or change anything. All right. Collagen wrapping, another collagen conduit study in a rat model at Mayo by Shin and Bishop. They found that when they repaired it and then put a collagen wrap around it, it reduced the epidural scar that they saw on histology, but there was really no difference in the force recovery between the two groups. Okay, so we talked about collagen, we talked about porcine ECM, amnion, that sounds sexy. So who doesn't like babies, right? So, well, flexor tendons don't, for one. Amnion was actually studied in human trials in 5 flexor tendon repairs. After they did the 5th person, they had such dismal results that they actually stopped the trial and discontinued it because there wasn't enough clinical equipoise to continue the trial, basically. When they harvested and looked at the native tendon sheath and looked at the area with the amniotic wrap when they took a sample, because they went back in and did a tenolysis on at least one of these patients, and they found there were significant areas of fibrosis in the group that had the amnion on it. When we look at it in nerves, similarly, there was actually no significant difference in functional outcome in an autograft model. So they would take the autograft, reverse it, and do a repair, and they put the amnion and wrap it around it. And what they really found was that there was no difference in the total axon number or the percentage in terms of the collagen deposition either. All right, so my thoughts, this is my guess. I didn't see Dr. Recan's slides, but my guess was that he was going to tell you that this beautiful amnion, that look at all these cells and it's babies and it's regenerative and all this, and there was going to lead to increased nerve regeneration. That would lead to less pain. Less pain equals a win. We all go home happy. I thought also might show some fancy animal models. There is at least one study that shows an improvement with amnion, to be perfectly fair. They compared collagen and amnion wraps to a control with a reverse sural repair. And they found there were better CMAP amplitudes with the amnion, less nerve adhesions, and perineural fibrosis. So why not let's just put amnion on everything, right? But if you look at, this is the collagen one, but this is back to Sammy's study, and look at this histology, and this doesn't look like a great nerve. So it looks like a compressed, unhappy nerve that's right around all this kind of fibrosis around it. That doesn't look great. And then when you look at, forget about the animal studies for a second, we actually look at the human data. So this is, I think, one of the ones they showed. Porcine extracellular matrix wrap with recurrent carpal tunnel syndrome. 12 patients had a revision carpal tunnel. They had better pain. They had almost 80% had symptom reduction, but there was no control group. They had small numbers, and there were no objective measures. There wasn't EDX, there wasn't grip or pinch. People just said, yeah, I seem better. When a human amniotic membrane wrapping the ulnar nerve, there was a trial of that as well. It's a retrospective review of a surgeon's case series where they did basically a normal cubital tunnel surgery, and then they did a review of when they started doing amnion wrapping. And they found, the authors concluded that this was helpful and that the amnion was reduced recurrence of symptoms because they found that there were higher recurrence of paresthesias in the no wrap group. But when you look at it, there was actually a significantly higher grade of disease in the control group. The amnion group was healthier people. They had their nerves were not as sick. They also had a higher number of transpositions in the control group, so it was more trauma to the nerve. Also, there was a longer time from surgery to the chart review, so a higher or greater chance that there could be a recurrence. And the wrap patients were significantly younger, so their nerves were going to recover better regardless. And if you look at, there's a cubital tunnel, recurrent cubital tunnel with the porcine ECM that was wrapped around it, pain got better, grip strength improved, pinch improved. But if you compare that to say, but there was no control group again. If you compare that to historical control with a cubital tunnel treated with an adipofascial flap, 8 patients, their pain also got better. Their McGowan stage also improved, which looks at strength. And the ultrasound showed gliding at the elbow as well. So there's lots of ways to get there. And what I always worry about, this kind of makes me think about, if you have an open tibia like this is a bad problem. And in treating wounds and injuries like this, I think there's sometimes a tendency to say, well, we don't have a great solution. There's nothing easy. Let's just kind of throw on whatever I'm told was the right thing and the kind of the newest thing. How do we fix this? And so dermal matrices, I think, sometimes get overused in areas where they don't. But just because you have a bad problem doesn't mean that that the tools that you have at your disposal are sufficient or should be employed. Sometimes you just need to kind of think creatively and have a different solution that might involve a different technique. And so in this case, a latissimus free flap solves the problem. So, this is an incomplete talk because I'm waiting for the slide that can show the rigorous clinical trial of human amnion and collagen and porcine ECM. And when that is done, I'd be happy to update the talk. And otherwise, I'll just sit in the corner here. And then I think this take is also in line with what has previously been published in the past year or so in JHS, that there's just not enough evidence right now to support the different ways that we potentially could use this in the hand and the wrist, and more needs to be done. And that's, I think, the take-home point, is that, animal models are highly variable. There's different wraps, different outcome measures, and there's even mixed results even with all that. The human studies are small case series. They don't have proper comparison groups. They look at different time points and different outcomes. And this isn't to say that there's no role for nerve wraps at all. I don't know that. And I think that, like anything, the truth is probably somewhere in the middle. I think that they may prove helpful in the future. And there is some encouraging data, but I don't think it's the panacea. I don't think we quite know when to use them yet. And so I would just urge caution before kind of throwing them in on everything. And this is another homage to Office Space. Those of a certain age will appreciate this. And I'll leave you with those final thoughts. So thank you for the chance to talk.
Thank you, David, very much. It's excellent presentation. Thank you. Would like to start the debate now. So if the four speakers, if you would unmask yourself, just video and audio, and we'll start the debate. We'll start with the two first speakers. Are you there?
Oh, we're here.
Okay,
Yep.
all right.
We're here, Nash.
Okay, I have a question to Dr. Porchal. Now, the impressive results that you showed us with electrical stimulation, have you reached the stage in which you can really use this in your clinical practice to a significant degree? And if so, when do you decide I'm going to really use electrical stimulation for this patient, but not for the other patient?
Yeah, it's a great question, Nash, and thank you. So it brings up a point that Jonathan made. What about the logistics? Let's say you're a practicing hand surgeon, you're doing nerve surgery. What do you do in the OR? Short answer to your question is basically if we have a patient with a nerve injury and we have the opportunity to do it, we'll put the leads on. We'll generally stimulate for about 30 minutes. And the reason is I have the greatest confidence in the data that came out of our lab. And the reason for that is we didn't believe it either, to Jonathan's point. It seemed too good to be true. So we were collaborating with Tessa Gordon, who's one of the OG eStim people. And she's a dear friend and collaborator, but I didn't believe her. So we had to go ahead and repeat a lot of studies and redo it and redo it. And you saw the number of data points in these preclinical studies that we did. So eventually we were won over, so to speak. And in light of that, we've basically continued what we learned with the preclinical studies and translated that into our patients in the OR. So what we do now is we use a ubiquitously available signal generator. It's a Nicolette device. There's no disclosure here or anything. Any hospital that does craniotomy or spine surgery will have something like this. Initially, we started collaborating with the neuromonitoring people, but they told us, hey, we'll program this for you. You can use it. We'll just leave it in your OR and you can use it whenever you need it. So it's actually quite convenient. There are commercial products in development now. So it'll be interesting to see what happens there. There's also the checkpoint device, the little add-on thing, which, as I said, I haven't used myself, but I'm intrigued to see if anybody else has any experience with it. That would make life easier. But the bottom line now is based on the preclinical data from elsewhere in our lab, and also these randomized prospective controlled trials, I've been convinced to the point where I basically try to use it on every patient that has a nerve injury. Now, one caveat that I would offer to Jonathan's point is that let's say you're doing a carpal tunnel release, it's a quick operation. Do you really want to expend that amount of time for something that may not be of tremendous benefit for perhaps most of those patients? Maybe not. So you just have to think about that. And also, as Jonathan said, you can't have local anesthetic in the field because it'll abolish the action potential. And then that preclinical work was done as well. So you have to be very careful, no local in the field, and you have to stimulate the proximal stump.
Thank you. Question to Jonathan. You invented the fantastic nerve tape, which is extremely impressive. Would you like, or would you be tempted to use electrical stimulation in addition to your nerve tape to enhance the growth of your nerve repair?
Well, I think, and again, remember, as I started the whole thing saying this is a debate, I'm going to present a negative side. One of the ways I think about treatment interventions is would I do it to my mom if she had unfortunately had a nerve injury, and I might. I mean, the data, there's a lot of compelling data. Like I said, I hope I gave people things to think about. We shouldn't swallow Kool-Aid too quickly. And when a convenient way to do eStim comes out, I suspect that I will try it in cases as a full disclosure. And if I didn't say all that, then I'd be a total hypocrite to say that, yeah, I'd put it in the nerve tape as soon as we can. As it turns out, the metal in nerve tape is nitinol, and that doesn't conduct a current. So we wouldn't be able to just hook up wires to nerve tape, but certainly the idea of using this as a different delivery tool, yeah, sure, that would be appealing to us. It's something that we definitely have thought about.
Thank you. Question to Dr. Rekant. With respect to also the nerve wrap, just tell me, in your practice as well, just to let all of us know, when do you use that, and in what kind of indications do you feel that this has a place in your clinical practice?
Yeah, great question. And in fairness to David, I think part of my research group is trying to classify when to use a nerve wrap versus amnion versus nothing. And a shameless plug, our paper is going to be presented at IFESH in Washington, D.C., where you're a chairperson. So, it really is, for me, when the nerve bed is poor. I think Dave's point to use amnion in a primary ulnar nerve decompression is likely going to be found to be unnecessary. In our paper that's coming out, that nerve bed would not be something that you would want to use a nerve wrap because it's healthy and, as Dave showed, is unnecessary and may in fact be unhelpful. So I think for revision cases, or certainly a revision case, I think the amniotic cell gives us options for the patient, albeit even if there is a placebo option or benefit to the patient, I think there's value.
Thank you. Last question to Dr. Brogan. Do you feel tempted sometimes to try to use some sort of nerve wrap during your practice?
Oh, sure. Yeah, and I enjoyed the talks overall, and Mark's talk was great. So I see the temptation, and I think the sick ulnar nerve is a unsolved problem, and we all have those patients who come back and have had a previous cubital tunnel, and now they're having problems again, and then you keep releasing it and revising it, and those patients do kind of worse and worse and worse, and I don't know that we have a solution for that. So I see this temptation. I hope that it works. I think that we just need some more data about it. And I think that wraps also might be a great drug delivery device, whether it's through anti-fibrotic properties or something for nerve growth factors. I think there's promise there as well. So I think more to come on it. I just don't fully understand it yet.
Greg and John, there's some chat questions. I don't know if you guys have a moment or two to respond to them verbally or by chat. Yeah.
Yeah, there was a chat from Oren McKaylee who said, I have a free functioning muscle transplant coming up in a couple of weeks. Have you used eStim in this sort of setting, thinking about giving it a try? Yeah, we've used it for free muscle transfers. And again, the key things to know: stimulate the donor nerve. You got to stimulate the nerve. Again, no local in the field, no paralysis as well. That's an important consideration too. So yeah, you can use the same stimulating leads, put it on there. We've done it. We haven't published on it. One caveat, I'm not sure if anyone has yet. I don't know. And then in the series so far, we haven't noticed any decline, and the outcomes, like the strength of these free functionals, has been pretty impressive. Admittedly, subjectively, we have yet to actually get the data and publish it.
Thank you. Other question: anyone using a checkpoint for intraoperative stimulation after nerve repair? Greg?
Yeah, I have done it. I have done it. It's a little bit painful, a little bit ghetto, because you're sitting there with the checkpoint stimulator on the nerve, and somebody's got to hold it there. So if there's a medical student in the case, they often get relegated to being the checkpoint holder for as long as they can do it. It's usually something like 15, 20 minutes. The checkpoint device does not produce stimulation at 20 hertz. The checkpoint device produces stimulation at 16 hertz. And then If you ask people, neurophysiologists, they'll say it's probably okay to do it. And then another question that sometimes comes up is, why is it 20 hertz? And it was just basically the resting firing rate of human motor neurons that was chosen initially in these early studies in the 1950s and beyond.
Thank you again very much. It's 9 o'clock. Thank you very much to the presenters. Really appreciate it. Fantastic presentations. I would like to ask Dr. Jain to conclude this session. Thank you.
Yeah, thank you, Nash, for wonderfully moderating, or should I say refereeing this debate, and to all of our incredible speakers for exceptional talks on really two hot topics in hand and nerve surgery. You really argued your points effectively, and you're professional, and there were no below the belt hits. That's great. Well, at least there weren't too many. And special thanks to Checkpoint for supporting this educational program. We at the Hand Association are grateful for that. Finally, I'd like to thank you, the audience, for spending your evening with us, and invite you to join us next month for our Hand in Hand webinar series with the American Society of Plastic Surgeons. Please look for details at handsurgery.org. Have a good night.
Thank you.